Welcome! The following presentation from Answers in CME is part of an educational activity titled KIT D816V in Focus, Optimizing Diagnosis and Tyrosine Kinase Inhibitor Therapy in Advanced Systemic Mastocytosis. To access the full program and supporting materials and to claim your certificate, please visit the activity URL in the episode description. This activity is supported by an educational grant from Blueprint Medicines.
Hi, I'm Prithvi Bose, professor in the Department of Leukemia at MD Anderson Cancer Center in Houston, Texas. Today, we'll be talking about advanced systemic mastocytosis. In this session, I will review diagnosing and recognizing advanced systemic mastocytosis. Advanced SM is about 10% of all SM. When it is just SM and there's no other hematologic neoplasm and you have organ damage via C findings, that's aggressive SM. When you have SM with another associated hematologic neoplasm, that's SM-AHN, and then we have mast cell leukemia, which is the third form. So advanced SM comes in these three flavors, most common being the SM-AHN. And there, one has to be careful whether the organ damage is from the SN component or the AHN component. The C findings in systemic mastocytosis define this organ damage from the infiltrating mast cells. That's a very important concept. C finding is where the mast cells are causing the organ damage. Organ damage is where the focus is. This can be subtle, it can be obvious. Now, of course, there are symptoms. They are less prominent in advanced disease, but you can have GI, skin, CNS, constitutional and musculoskeletal. And then one can also have, not just in advanced SM, but SM as a whole, bone loss. So low bone density, osteopenia, osteoporosis. Just as a concept, the symptoms, the anaphylaxis, in advanced SM, they are less common. The KIT D816V mutation underlies the vast majority of cases of SM, 90 to 95%. It's no different in advanced SM, where the VAFs tend to be higher than in those with indolent disease. And we know that higher KIT VAFs actually have a prognostic importance. In the context of certain therapies, we found that if you have less than a 25% reduction of the KIT VAF, that correlates with a worse outcome. There are, of course, other mutations which are adverse as well and are often seen. Just one comment on the KIT D816V testing, especially in indolent SM, where the VAFs are lower. It may be missed if one just uses an NGS panel, which is what we often start with. So it's important if SM is suspected and you're not picking it up on the NGS, then you get a highly sensitive assay for KIT D816V, such as a digital droplet PCR or an allele-specific oligonucleotide PCR. We will get to the treatment in the next session. In this session, I will review guideline recommendations for advanced systemic mastocytosis. It's important to really look for those C findings, the organ damage. And then this is such a rare disease that it's always advisable to consult with an SM expert or a center with expertise in mast cell disorders. Everybody needs to have an EpiPen. Patients need to know the triggers for their symptoms, even if symptoms are less pronounced in advanced disease. Among the drugs, we have avapritinib and midostaurin. Avapritinib should be used only if the platelets are above 50,000. Sometimes we use cladribine when it's important to rapidly cytoreduce the mast cell burden, and imatinib, which is only patients who do not have the KIT D816V mutation, which is a very small minority, and those in whom the mutation status is not known. With the sensitive testing that we talked about, that scenario should be pretty rare. When thinking about advanced SM, we said that if the KIT mutation is truly not there, imatinib may have a role, but most of the time it will be there, and that's where we have avapritinib and midostaurin. Aggressive SM, I would argue, generally would respond very well to our current therapies, particularly avapritinib, because many of these patients will have SM-AHN, so two diseases, and it's important to figure out what is causing the organ damage. If the organ damage is from the SM component, that's when it's called a C finding, and that's when it's important to treat the SM component in an aggressive manner. Some patients will need stem cell transplant, especially those with SM-AHN, where you know that the AHN component will need some help beyond the KIT inhibitor and mast cell leukemia. In the next session, we'll go over the efficacy of approved KIT D816V inhibitors. In this session, let us review efficacy of KIT D816V inhibitors for advanced systemic mastocytosis. The first one approved was midostaurin, which is a multi-kinase inhibitor hitting both wild-type and mutated KIT, as well as some other targets. This is really the first targeted therapy. Median survival of the whole cohort was about 28.7 months. PFS was about 14.1 months. MCL, although there were only few patients, did much better than had been known to do. And what was really striking is that we really saw very nice reductions in measures of mast cell burden. So this at the time was a significant advancement. Fast forward 5 years and avapritinib was approved based on the phase 1 Explorer and phase 2 Pathfinder studies. Pathfinder is a bit more relevant because this is a study where almost everybody started with 200 milligrams, whereas Explorer was a dose-finding study. So in Pathfinder, even with 4 years of follow-up, the response rate has been very robust. The median survival, 62 months, significantly, notably higher than what is expected for such a cohort. Median PFS, 51 months. Median duration of response, 58 months. Compared to historical controls, obviously this is an open label single arm study, these numbers would be much better than expected. And again, I find it impressive that the overall response rate has stayed so similar to what we started with. Now, also important to say that patients with SM will have low bone density. This is something we would just treat as we would treat normal osteoporosis. Intriguingly, it is emerging that drugs like avapritinib, and we'll come to bezuclastinib later on, can improve bone density. That was seen in both the Pioneer trial in indolent SM and in the Pathfinder study in advanced SM. These trials are all single-arm trials. It's too rare a disease to do a randomized trial in. For those reasons, there have been efforts to look at real-world cohorts and compare the avapritinib results from Explorer and Pathfinder to these retrospective chart-reviewed studies. One of these was just published to show that with avapritinib, the efficacy was significantly better in terms of overall survival versus both midostaurin and cladribine in separate comparisons. In the next session, we will review safety considerations and appropriate KIT D816V TKI use for advanced SM. Let's talk about balancing efficacy with tolerability in this session. Avapritinib and midostaurin have quite different tolerability profiles. So midostaurin is a multikinase inhibitor. It does hit both wild type and mutated KIT, but the main clinical adverse event that patients experience is GI. They have nausea, they can have vomiting, diarrhea, but nausea is a big one. That was prominent enough that when the original pivotal trial came out, they showed that symptoms generally improved with midostaurin, but not GI symptoms. Obviously, SM can cause GI symptoms, but midostaurin side effects probably outweigh any benefits in the GI domain as far as symptoms are concerned. But it is an efficacious drug for advanced SM as a whole. GI side effects are the most important to counsel patients about and have the antiemetics, the antidiarrheals handy. Also, midostaurin, because of the other targets that it has, wild-type KIT being among them, can be myelosuppressive. That also can be of some consequence in this population where many have low counts to begin with. Now, avapritinib has some of its own unique side effects. GI is among them, but not as prominent. Edema is very common. Periorbital edema, peripheral edema, extremely common. So patients need to know about this. It's not really dangerous, but more of a cosmetic thing, certainly something that can be worrying to patients if they were not expecting it. What's important really is to talk about intracranial bleeding and cognitive effect. Avapritinib does cross the blood-brain barrier. In the Explorer trial, quite a few intracranial hemorrhages were picked up largely because scans were being done looking for them. So it's important to note that many of them were not necessarily symptomatic. Subsequently, it was realized that should not be used with platelets less than 50. It can induce a platelet function defect, and you don't want patients with low platelets on these drugs. That mitigates this risk of intracranial bleeding. Also, one has to be careful about blood thinners or anything else that may contribute to a bleeding risk in these patients. Cognitive effects are also possible with this drug, and they can be fairly significant, which is why even though the starting dose per label is 200 milligrams, in my practice, I tend to start with 100 milligrams in my advanced SM patients. In the final session, we will review the evolving therapeutic landscape for advanced systemic mastocytosis. In this session, we will take a look at emerging therapies for advanced SM and their possible role in future treatment algorithms. Currently, we have midostaurin and avapritinib, and perhaps the next one approved would be bezuclastinib. Bezuclastinib is, like avapritinib, a potent and selective inhibitor of KIT D816V, which affects against the wild type. However, it has a few differentiating points. One, it does not cross the blood-brain barrier to any meaningful degree. So we shouldn't have to worry about the cognitive adverse events, for example, or the intracranial bleeding. Also, it does not hit a range of other off-target kinases which are hit by avapritinib and may be responsible for certain side effects of avapritinib. They're about equally potent against KIT D816V, but the wild-type KIT is actually hit more by bezuclastinib. This translates to the whitening of the hair, which is a prominent side effect of bezuclastinib, not a problematic one for most patients, but something that is quite striking. In the context of this discussion, we'll talk about the advanced SM data. That's called the APEX trial. We don't have a formal presentation yet, but what was striking was that those measures of mast cell burden were profoundly reduced, going down in almost 90% of patients by 50% or more. The overall response rate was, however, 57% if you use the same criteria as were used for avapritinib. Remember, avapritinib was in the 70s. It is pertinent to mention, though, a separate set of criteria called pure pathologic response, PPR, which does not take into account resolution of organ damage like the traditional criteria do. If you look at it with PPR, you see 80% response rate as opposed to the 57 by the modified IWG. You get very high response rates to avapritinib as well by PPR criteria. With Bezu, I don't have to worry about the cognitive effects or the intracranial bleeding. And in certain patients, that may lead me to choose Bezu. But efficacy-wise, I think Ava still today has an edge in advanced SM. Let's summarize the big takeaways. Number one, whenever you are evaluating somebody that you think has advanced SM and you're not picking it up on the NGS, then you get a highly sensitive assay for KIT D816V, such as a digital droplet PCR or an allele-specific oligonucleotide PCR. It's important to see what those C findings are. Where is the organ damage? And is that organ damage a result of the mast cells, or is it due to the other hematologic neoplasm that they have? Because keep in mind, many of them will have SM-AHN. Then as we come into treatment, there are two drugs approved for advanced SM, midostaurin and avapritinib. Of the two, avapritinib is the far more selective agent, much more potent as well as a KIT inhibitor. Very impressive long-term results in terms of both response rates and survival outcomes. I think clearly a drug of choice for patients with advanced SM. Another thing is that it is important to order high sensitivity KIT assays so that we don't miss the mutation now that we have such good targeted therapies. For the emerging landscape is primarily bezuclastinib in the near term, and we await hopefully in 2026 to see the full data from the APEX trial.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.